In general, cancers that are hormone receptor negative and HER2 positive are more likely to have a complete pathologic response compared to cancers that are estrogen receptor positive and HER2 positive. This has been shown in almost every trial that has looked at preoperative HER2-directed therapy. We don't really know why that is, but it does appear that these HER2 positive cancers are quite heterogeneous at a molecular level. So for example, most estrogen receptor negative HER2 positive cancers have a HER2 phenotype if you use intrinsic subtyping. But very interestingly, the ER positive HER2 positive cancers tend to be much more heterogeneous, with most of them being luminal B, but actually a fairly significant number being luminal A cancers. So that perhaps explains the difference in pathologic complete response, because luminal A cancers generally, most patients do not get a pathologic complete response to preoperative chemotherapy versus some of the other subtypes of breast cancer. So I think overall this is a pretty typical presentation of a cancer like this, and the fact she had a pathologic complete response rate is what we would really expect, because we do see that in 50 to 60% of patients with the regimen that this patient received. As far as doing other molecular testing, I wouldn't have done anything else. But as I mentioned, if you use intrinsic subtyping, it is interesting from a research perspective in that these cancers are heterogeneous. We also know, looking at intrinsic subtyping, that the HER2 phenotype is more likely to have a pathologic complete response compared to the luminal A or luminal B phenotype, even for HER2 positive cancers. I would consider this patient high risk because she does have a node-positive breast cancer, and also it's estrogen receptor negative. Looking at the early adjuvant studies that were done, interestingly, the risk of relapse with longer follow-up is in the range of about 25%. So although we are curing the majority of these patients and they're not having relapses, there's still a fairly significant percentage of patients that actually do relapse with longer follow-up from these adjuvant trials. So based on the data that we have available, the NCCN does recommend consideration of a preoperative approach for cancers that are certainly over 2 centimeters, particularly if they're node positive. But some people would actually consider giving preoperative treatment for cancer that's over 1 centimeter. The rationale for this is that we know that there's a high likelihood of pathologic complete response, particularly if the cancers are estrogen receptor negative, and the achieving a pathologic complete response is associated with a very positive prognosis going forward. So in general, I think most of us would use a preoperative approach to treat most early stage HER2 positive breast cancer. Exceptions would be if you think the cancer is under 2 centimeters and node negative, in which case you can get away with the APT regimen, which is essentially 12 weeks of paclitaxel with trastuzumab given weekly through the chemotherapy, and then every 3 weeks for a total of a year. So in those very low stage cancers, there's a possibility of de-escalating therapy. So those patients I would not necessarily give preoperative treatment to, just because I feel like we can get away with less treatment for those patients. But by far the majority of patients, we're going to use a preoperative approach. I generally use the TCHP regimen that this lady got, which is docetaxel, carboplatin, trastuzumab, and pertuzumab. Other options would be to consider using an anthracycline-based regimen with adriamycin Cytoxan followed by paclitaxel and trastuzumab. I don't typically use that regimen. I might consider using it in a younger patient who, particularly if you're trying to maintain fertility for that patient. But in general, I tend to use TCHP for almost all patients preoperatively. The question is, if you could de-escalate therapy in some patients by maybe giving them paclitaxel trastuzumab first, maybe taking them to surgery afterwards, and then giving them adriamycin Cytoxan if they don't have a pathologic complete response. I'm not really in favor of that approach, because we now have data from the Catherine study basically showing that if you use trastuzumab DM1 in patients who have residual disease after preoperative chemotherapy with HER2-directed therapy, you can really improve their outcome by using trastuzumab DM1 versus trastuzumab alone. Pathologic complete response is a very important prognostic factor for HER2 positive breast cancers, particularly when they're estrogen receptor negative. And what that basically means that in patients who have a pathologic complete response, their likelihood of recurrence is very low, probably less than 5 to 10%, versus patients who have residual disease. We do now have an option for patients with residual disease in that we can give them trastuzumab DM1, as was seen in the Catherine study. In ER-positive, HER2-positive breast cancers, pathologic complete response rate still remains a significant prognostic factor, but it's not as robust a prognostic factor as it is for estrogen receptor-negative, HER2-positive breast cancers. And that's why taking hormone receptor status into account does make sense in these cancers, so that I think that in a patient who is a hormone receptor-negative, HER2-positive breast cancer, we certainly would be more likely to recommend a preoperative approach in those patients. And then the good news is, like in this patient here, that if they have a pathologic complete response rate, you know that their prognosis is going to be very favorable going forward.